Hello everyone and welcome to lecture 79 of this series. This series of lectures is based on my book Manual of Fluid, Electrolyte, and Acid-Base Disorders, a pathophysiologic approach to common clinical problems. I am Dr. Mohammad Tinawi. I'm a nephrologist in Northwest Indiana. You can find the book on Amazon at the link below. We are still on chapter 11, the last chapter of my book, Intravenous Fluids, Chemistry and Indications. Today we are going to discuss in detail colloid intravenous solutions. There are several kinds of colloid solutions. They're used less often than crystalloid solutions because they're less widely available and more expensive. The most common is human albumin. Also, you have hydroxyethyl starch, dextrans, and gelatins. Dextran is available as dextran 40 and dextran 70. We have to say that dextrans and gelatins are very rarely used, and they are associated with anaphylactoid reactions. Let's discuss human albumin. Human albumin is available as 4%, 5%, 20%, 25% solutions. Most commonly used are 5%, 20%, and 25%. We have to say that human albumin 20% is a low salt albumin because it has a content of sodium of 125 milliequivalents per liter as opposed to about 154 per liter for other solutions. The advantage of albumin, it remains essentially all of it in the intravascular compartment, so we can use less volume of fluid to achieve resuscitation. It has a molecular weight of about 69,000 Dalton, and albumin increases oncotic pressure because it's protein. It increases oncotic pressure in the plasma, and its half-life is long, 16 to 24 hours. We have to monitor patients for allergic reactions, although these are rare. When we give albumin, we raise oncotic pressure. So for each 1 gram of albumin, we are going to pull 18 mLs of water. For 25% albumin, the maximum expansion volume is 300 to 500%. So if you give 200 cc's, you're going to get like 800 cc's because you are going to pull water into the circulation. So for example, if we use the traditional 100 ml vial of 25% albumin, we are going to expand the intravascular compartment by approximately 450 ml. This is equivalent to giving 1.8 liters of isotonic saline or lactated ringer. So it's very effective in that regard. Normally, we give 5% albumin, 12.5 to 25 grams, and this is done over 30 minutes. Many times, especially in dialysis, liver cirrhosis after paracentesis, we give 25 gram albumin. This comes in 100 ml vial, and it's 25% albumin, so out of 100 ml is going to be 25 grams, and we give it over 2 hours. International guidelines recommend albumin infusion in patients with hepatorenal syndrome, spontaneous bacterial peritonitis, and post-large volume paracentesis because it has an anti-inflammatory effect. 25% albumin is commonly given after large volume paracentesis, and the dose is 5 to 10 grams per each liter removed. So if you remove 5 liters, you're going to give 25 to 50 grams. Now let's look at this recently published study in the New England Journal of Medicine, albumin in decompensated liver cirrhosis. Albumin infusion was investigated in a randomized trial in 777 patients hospitalized with decompensated liver cirrhosis. Their albumin was less than 3 on admission, and the primary endpoint was the composite of infection, renal dysfunction, or death 3 to 15 days post-hospitalization. The albumin group received 143 grams of albumin on average, more than the standard group, so a lot more. The trial concluded that albumin infusion to increase serum albumin to at least 3 had no benefit in patients hospitalized with decompensated liver cirrhosis. So you don't need to give it to someone with decompensated liver cirrhosis unless there is a reason. You want to expand volume, maybe you've done large volume paracentesis, there's hypotension, but just to give it for the sake of it is not beneficial. The SAFE study showed that giving 4% albumin in the resuscitation of critically ill patients is safe, but it had no advantage over isotonic saline. In this study, we had about 7,000 patients, and they either received 4% albumin or isotonic saline for intravenous resuscitation. Now, the primary outcome was all-cause mortality at 28 days, and there was no difference. So this is the first comparison, first study we are discussing comparing human albumin versus isotonic saline. Now, there was also no difference in the need for renal replacement therapy, no difference in length of stay in the ICU or days on mechanical ventilation. In a pre-specified analysis in patients with severe sepsis in the trial, 4% albumin was advantageous. It was associated with a lower adjusted risk of death compared with isotonic saline. Now, this finding was bolstered by a finding the same thing in a meta-analysis, and you can find both references on the screen. So in other words, human albumin might have an advantage in patients with severe sepsis. What about human albumin in traumatic brain surgery? Well, don't use it. Albumin should be avoided in those patients. Why? The same study, they did a post hoc analysis in 460 patients who were critically ill but also had traumatic brain injury. They had actually high mortality. So the relative risk was 1.63. The p-value was significant. So in patients with traumatic brain injury who are critically ill, do not use human albumin because it increases intracranial pressure. Let's look at another study, the CRYSTAL study, colloids versus crystalloids. This was a multi-center international study published in JAMA, conducted over 9 years in 57 intensive care units. It had about 3,000 patients with hypovolemic shock. They were randomized to receive colloids. It could be either a hydroxyethyl starch, gelatins, dextrans, 4 or 20% albumin versus crystalloids. The crystalloids were LR, isotonic saline, or even hypertonic saline. In this study, there was no significant difference between the two groups in the 28-day mortality. Now, patients receiving colloids had lower 90-day mortality. Okay, so no difference in 28-day mortality. In the 90-day mortality, there was an advantage for colloids. The author emphasized that this is exploratory and needs further studying. The Albios study, colloids versus crystalloid, another example, New England Journal of Medicine 2014. This was a multi-center open label study in about 1,800 intensive care patients with severe sepsis. They were randomized to receive 20% albumin and a crystalloid or just crystalloid. Target serum albumin in the albumin group was equal or over 3. Now, in the first 7 days of the trial, patients in the albumin group had a lower net fluid balance, like you would expect, and a higher mean arterial pressure compared to the crystalloid group. However, there was no difference in the rate of survival at 28 days and again at 90 days, and no difference in length of stay in ICU and hospital. So you're starting to form this idea that crystalloids and colloids, there's really no significant difference in mortality. Maybe there is an advantage for colloids in severe sepsis, and maybe they should not be used in traumatic brain injury. What about the use of albumin for intradialytic hypotension? We nephrologists love that. It's used widely, and we believe that it works. However, clinical trials regarding the effectiveness of albumin in hemodialysis patients have been small, single-centered, and heterogeneous. So from an evidence-based standpoint, the evidence is shaky. What about the risk of acute kidney injury with hyperonchotic albumin? There has been some observational studies suggesting increased risk of acute kidney injury. Actually, in a recent randomized study in 220 patients undergoing off-pump coronary artery bypass surgery, the opposite was found. Patients with albumin less than 4 were giving 20% albumin, or the same volume of isotonic saline, and patients who received the albumin had less postoperative acute kidney injury, not more. A meta-analysis of 10 studies involving about 6,600 patients with sepsis also showed no increase in renal replacement therapy with albumin compared to crystalloid solutions. So now we've discussed albumin. Let's talk briefly about hydroxyethyl starch, or HES. People used to utilize this solution. Now it's utilized much less often. It's a synthetic colloid, and it is associated with anaphylactoid reactions like dextrans and gelatins. It's available in 3%, 5%, 6%, and 10% solutions. Its molecular weight is very high, 450,000 Dalton. Now the osmolarity is isoosmolar, pretty much 310, has a long half-life of 50 hours, and maximum expansion volume is 100 to 200. So if you give 100 ml, you are going to keep it in the intravascular space, or even pull another 100 mLs of water into the intravascular space. Randomized trials have shown increased need for renal replacement therapy and higher mortality in critically ill patients treated with hydroxyethyl starch compared to isotonic saline or lactated ringer. The reference is on your screen. A meta-analysis of 38 trials concluded that acute volume resuscitation in critically ill patients with HES also is associated with increased mortality and AKI. So now this product comes with that black box warning. Bottom line, why use it? You're going to have, it's expensive, not available readily, and you have more risk of death and AKI. So let's not use it. Now, let's discuss the FLASH study. This is fluid loading in abdominal surgery, saline versus hydroxyethyl starch. It was a multi-center double-blinded trial in 775 patients undergoing major abdominal surgery, and they were at risk of post-operative AKI. They were given either HES or normal saline starting at the time of surgery and up to 24 hours post-operatively. 14 days post-operatively, there was no difference in post-operative complications or death. However, at 28 days, there was more acute kidney injury. 23% in the HES group versus 17% in the saline group. So based on these results, there's no justification to use HES in this patient's population or in patients in general. Crystalloids are readily available, less risk of death, less risk of AKI, and much less expensive. I'm going to end here. In the next lecture, we're going to do some case studies.